Morning, everyone. Nice to see you all. Welcome back from the summer, and happy that so many people are here to celebrate our Mark Babiatsky lecture, which starts our academic year. And nice to see some of Mark's family with us today on Zoom. So with that, welcome to everyone. I'll turn it over to Dr. Sands to introduce our speaker for today.
Thank you, David. It's a pleasure to see you all here on this occasion. This is the 6th annual Mark Warren Babiatsky, MD Memorial Lecture. And I want to thank the Department of Medicine for sponsoring this, hosting this. Before I introduce today's speaker, I want to take a few minutes to remember Mark Babiatsky and remember what he meant to all of us. Mark grew up in a really tough neighborhood in the Bronx, but he really rose to the top in everything that he did. He attended Bronx High School of Science and then got his BA from Columbia. He went on to get his MD from Albert Einstein, and he graduated AOA. And over the next 4 years, he completed internal medicine residency and chief residency at what was then the Mount Sinai School of Medicine in New York. And Mark's impressive performance in residency was recognized by Doctors Kurt Isselbacher and Daniel Podolsky, who recruited Mark to the GI Fellowship program in the gastrointestinal unit at the Massachusetts General Hospital. And after his fellowship, Mark continued at MGH as a junior faculty member. In 1994, Mark returned to the Division of Gastroenterology at Mount Sinai. He continued his studies on mechanisms of mucosal repair and inflammatory bowel disease in the laboratory. And while he was a successful researcher in the laboratory, he found his true calling and his passion really as one of the most distinguished and cherished educators at Mount Sinai. He won numerous teaching awards at all levels of the medical school, and he was known for his mentoring skills of medical students, residents, fellows, and postdoctoral scientists. In 2002, Mark became director of the internal medicine residency program and co-program director of the internal medicine pediatrics residency and vice chair for education. And in the next 8 years, Babs, as he was fondly known here, nurtured and promoted the careers of over 400 residents and fellows. His teaching rounds, affectionately known as Babiatsky rounds, were the highlight of the week for all interns and residents who knew they would walk away with clinical pearls and newfound insights into all types of diseases. He earned his national recognition among internal medicine program directors and became the founder and director of the Education Research Consortium of Program Directors, and working with the American College of Physicians as member of the In-Training Exam and Education Research Committee as an ACP representative to the NIH's Genomics Consensus Conference on developing a blueprint for primary care physician education in genomic medicine. And in 2010, Mark became chair of the Samuel Bronfman Department of Medicine, professor of medicine at Mount Sinai. He made a huge impact on the educational and research missions of the department, as well as on patient safety and quality improvement programs and multicultural affairs. In 2014, he assumed new challenges as the chair of medicine at Monmouth Medical Center in St. Barnabas Medical Group South Region. Mark, as a person, was really unique. He had a photographic memory and an encyclopedic knowledge of not only medicine, but also the arts, theater, science, and politics. And he knew every movie that came out. He had seen it, read the book, knew the director, producer, all the actors. Really, he lay odds on the Academy Awards every year and usually was correct. He also embodied the keenest doctoring skills. He had an innate ability to mentor and guide trainees. He had a truly effortless talent for teaching and an incredibly accessible body of knowledge for both medicine and life. And what really distinguished him from so many other gifted scholars and educators was his caring manner, his compassionate personality, his genuine interest in everyone he met, and really his magnetism is how I would put it. Everyone was drawn to him, and everyone who knew Mark felt as though they had a unique and close personal connection to him. He exuded optimism, warm humor, friendliness to people of all walks of life, and he affected so many people in ways perhaps that he never fully knew. So we take this occasion to remember our friend Mark and to honor him and cherish that memory. So now, in his memory, it is my really distinct pleasure to introduce the 6th annual Mark Babiatsky MD lecturer, Dr. Daniel Chung. Dr. Daniel Chung is medical co-director of the Center for Cancer Risk Assessment and director of the GI Cancer Genetics Program at Massachusetts General Hospital. He's also professor of medicine at Harvard Medical School. He received his MD degree from Harvard Medical School and completed residency in gastroenterology training at MGH. His work is focused on clinical cancer genetics, and his research group is interested in the molecular genetics of GI cancers. He also looks at genotype-phenotype relationships in hereditary cancers and novel approaches to screening for GI cancers. He's been a PI on over 20 research grants, has served as the chair of the AGA GI Oncology section and program committee chair of the AGA Astro SSO GI Cancers Symposium. And he currently sits on the NCCN Guidelines Committee for Hereditary Colon Cancers. Dr. Chung exemplifies the very best of academic gastroenterology and was also a dear friend of Mark Babiatsky. I recall having many lunches when we were fellows together. Dan was 1 year behind me. Mark was 2 years ahead of me in our training. And I really am so pleased that he's joined us today to honor the memory of our friend, Mark Babiatsky. Dan, thank you so much for joining us from Boston.
Bruce, thank you so much for that very kind introduction. It's really just a pleasure to be here today, and I want to thank all of the organizers for really including me in this special event. It's really quite an honor to be here at this lecture that recognizes Mark Babiatsky, who, as Bruce has mentioned, is really just a dearly missed leader, true inspiration, and just an esteemed colleague both in the world of internal medicine and in gastroenterology. So thank you. So what I'd like to do this morning, and I'll share my screen here, is share with you the arc of progress in the field of genetic testing and hereditary cancer syndromes. And I will naturally focus a little on GI cancer syndromes, but really the lessons and the messages are relevant to hereditary cancers of all types. My goal is really to kind of highlight some of the common themes and share where we've come from, the current state of testing, and then really what the future holds. So in terms of disclosures, these are my disclosures, none of which are really relevant to today's talk. And to just jump right in by way of background, genetic testing is now really a standard part and a routine part of medical practice in 2022. There are tests available for thousands of disorders, and they're broadly divided up into tests that we consider either diagnostic, predictive, or pharmacogenetic. And the tests we'll talk about today are primarily predictive in terms of cancer risk. It goes without saying that genetic testing is now the standard of care for the diagnosis of hereditary cancer syndromes. And a number of analyses have shown that, the number of tests being performed continues to rise every year, and it's predicted to remain strong for many years to come. So, this field is really only about 30 years old or so, because it was in the early 1990s, when the first hereditary cancer genes were cloned. And those were the genes for FAP, the APC gene, genes for Lynch syndrome, as well as the BRCA genes for the hereditary breast ovarian cancer syndrome. And over that time, there are a couple of very kind of important trends that I wanted to highlight. And number one, of course, is that the number of genes that we now associate with hereditary cancer risk has exploded, and there are hundreds of genes now that we recognize can increase cancer risk. The second important trend is that the cost for testing has dramatically fallen. And so in those early days, it was $3,000, $4,000 to get a single test. It's now down to about $250 out of pocket to get a multitude of tests done all at once. And I think some of that, of course, is naturally due to advances in next generation sequencing. But I think an important landmark was in 2013 when the Supreme Court overturned the ability to patent genes. And the final trend, which I think has really been an important addition, is that in 2008, the so-called Genetic Information Non-Discrimination Act was performed. There's previously been a lot of concern about so-called genetic discrimination based on test results, and this was an important piece of federal legislation that provided nationwide protections really against genetic discrimination in the areas of healthcare as well as employment. So in that backdrop, then, I just want to just give you a sense of sort of the magnitude of all the genes that we now see. There are, as I said, hundreds of genes, and they can all be categorized and broken down into the tumors that they are associated with among different organ systems. And I think this just highlights the breadth and the depth. There are multiple genes for every type of organ system, and there's no organ system that is untouched or unaffected by these particular family of genes. I did want to take one quick sec to just do a little bit of a deeper dive among cancer, GI cancer syndromes, just to give you a sense of the spectrum within one of these organ systems. Lynch syndrome is probably the most common of all of the hereditary GI cancer syndromes shown here. And it probably accounts for maybe 70 to 80% of all individuals who have one of these conditions. And of course, there are many, many other cancer predisposing genes, mostly associated with multiple polyps. But we also know that there are many genes associated with hereditary forms of pancreas cancer, gastric cancer, neuroendocrine tumors, as well as GISTs. And this list continues to grow. And I just will want to highlight a couple of ones that have been recently identified in the past few years, including things like polymerase proofreading associated polyposis or serrated polyposis. And this list will continue to grow over time. I am not going to really get into the nitty-gritty of details of all of these syndromes, but I will highlight a couple as I discuss some of the major messages and themes. So what I'd like to do in the next 40 minutes or so is really just highlight a couple of major questions. And what are some of the main lessons that we have indeed learned over these past 30 years? In terms of what are the actual types of options that you have available, and who should be having genetic testing, which is probably the most pressing questions now. And then finish with a few comments on some of the challenges and potential solutions for genetic testing going forward. So one of the first lessons really is just recognizing that there is a real hierarchy of cancer risk alleles. And this is a slide that indicates sort of what we call the frequency, allele frequency here on the x-axis, as well as the penetrance or the extent of the cancer risk on the y-axis. And so among these hundreds of genes that we know, many of them fall into this green circle here, which are those single gene disorders inherited in a Mendelian way that are associated with very high risks of cancer and are really incredibly rare. And these are things like, FAP, Lynch syndrome, et cetera. And I would venture to say that really this box we've actually pretty much filled up. I think we've really identified really what most of the genes that fall into this category are. However, these categories probably continue to grow. And every year we learn about more and more genes that are probably more common, the so-called low penetrance alleles that are associated with much lower risks of cancer, but more common in the population. And I think that we have a long way to go to really understanding the full extent of these genes, as well as their full clinical phenotypes, and ultimately how to manage those individuals. I think probably one of the most important lessons, though, we've learned is that these hereditary syndromes are actually quite common, and they're not really as rare as you think. And so these are 5 of the most common 5 cancers that we know do have strong hereditary and genetic components. Just showing you the number of predicted estimated cases that we see annually now. And the final column is the percent of those cases that do actually associated with an underlying higher moderate penetrance cancer gene. And among all individuals with colon cancer, it's estimated anywhere between 4 and as many as 8% will carry one of these underlying genetic abnormalities. And that's actually at the low end when we look at some of these other genes. We now recognize that up to 10% of all pancreas cancers will have an underlying genetic abnormality. Even higher in breast and ovary is probably one of the highest, where we see up to 20%, or nearly 1 in 5 women with ovarian cancer will have an underlying genetic predisposition. Prostate is the latest cancer to join this list. But I think the main message here is that, for the broad spectrum of these tumors, at least somewhere in the 1 in 10, and as my understanding is 1 in 5 individuals with these cancers will indeed have an underlying hereditary gene. We have also been better at being able to precisely define and quantify really what the benefits are and the importance of recognizing these syndromes. And naturally, of course, anyone with one of these conditions, you're going to figure out what the right kind of surveillance strategy or risk-reducing approaches there are to take. But I think we've been able to show convincingly that performing these surveillance approaches actually does save lives and is actually truly effective. And I think the most important examples are, for example, the risk of reducing oophorectomy in BRCA carriers, clearly associated with an 80% reduction in ovarian cancer risk, 77% reduction in mortality. Regular colonoscopies in individuals with Lynch syndrome associated with a 70% reduction in colorectal cancer-related mortality. But the most exciting and important, I think, impact has been really on the ways that we now can treat patients who actually have developed cancer in the context of one of these syndromes. I think it's important to note that the surgical approaches will change. So, for example, in an individual with Lynch syndrome who has colon cancer, the standard recommendation of a segmental resection really should not be performed, but rather a subtotal colectomy because of the high risk of metachronous tumors down the line. And probably the most exciting thing has been the recognition that genotype can determine your eligibility for certain targeted treatments. And the PARP inhibitors really have taken center stage here, have shown that individuals who carry BRCA mutations with underlying breast cancer, ovarian cancer, but also breast cancer, pancreas cancer, and prostate cancer, are eligible for treatment with PARP inhibitors, and these have been shown to clearly increase progression-free survival. So there are pretty important treatment implications to recognizing those who have one of these hereditary conditions. Now, we've also recognized that it's important to define all of these syndromes really by what the gene is involved and not the underlying historical nomenclature. And it's particularly true when one syndrome may be associated with multiple genes, and really, as one syndrome does not really equal one gene. And I think Lynch syndrome, again, is a very good example of this message. So Lynch syndrome is the most common colon cancer syndrome. It's and in some populations estimated to be present in as many as 1 in 250 individuals. Inherited in an autosomal dominant manner, high risk of colorectal cancer and endometrial cancer with non-polyposis phenotype, so you don't really see a lot of polyps. We now know that this is due to a germline mutation in one of 4 DNA mismatch repair genes, MSH2, MLH1, MSH6, or PMS2. So that's great, we know the genes, but it turns out that it matters which gene is involved, and that Lynch syndrome is not the same based depending on which gene you have. Here's an example of a family that we see with an MLH1 mutation in the family, where it's a very classic picture that you see. Sort of this gentleman, our patient, had colon cancer 27, father had colon cancer 52, aunts and uncles had early onset colon cancer, cousins had early onset colon cancer. And so it's clear this is like a high penetrance colon cancer family. But the other end of the spectrum is someone who has a PMS2 mutation, who by definition now also has Lynch syndrome. But you can see this individual here, 73, has never had any cancer, hasn't had polyps. And when we take a family history, we find that there's absolutely no one who's had colon cancer or endometrial cancer in the family. But he does carry this pathogenic genetic alteration in PMS2. So this is where it becomes important to recognize that this person has a PMS2 mutation, not that they have necessarily just Lynch syndrome, because the guidelines now are all tailored towards these specific cancer risks based on these individual genetic variations. And so here's just to show you, to summarize that for you, the risk of colon cancer is probably the highest in MSH2 and MLH1 carriers, well over 50 to 60% risk, but clearly much lower in MSH carriers and extremely low in PMS2 carriers. And these individuals, if they do get cancer, tend to get them at an older age. Endometrial cancer is seen, again, MS2 and MLH1, but also very high risk in MSH carriers as well. And just to round out a couple of other highlights, we see ovary primarily in MS2 and MLH1, and certain urinary tract tumors primarily in MSH2. So it is absolutely critical that we recognize which gene is involved and not just clinically that they have Lynch syndrome, because our management and surveillance guidelines will depend entirely on which gene is involved. Now, just a quick word on semantics. The terminology that we use around genetic testing has evolved a bit. And when we talk about genetic testing, we are referring to germline testing that looks at constitutional DNA changes in either blood, white blood cells, or saliva. We are not talking about testing of tumor DNA for somatic alterations. We're not talking about circulating or cell-free tumor DNA, all of which have important roles in management, particularly of patients with cancer, but those are not constitutional germline changes. We have moved a little away toward trying to avoid the use of the term mutation just for the negative connotations and prefer to the use of the term variant. And you'll see in your reports that come back from genetic test labs that variants are labeled as either being a pathogenic variant, means in the old terms of mutation that really is associated with the disease, something called a likely pathogenic variant, where the data are not quite as strong, but essentially are treated as if it is a positive result and truly associated with that disease. And the third category, which is one that's been a little bit vexing really over the years, something called a variant of uncertain significance. And I just want to take 1 minute to just talk about that for a moment. So variants of uncertain significance are DNA alterations that are typically missense mutations, meaning a change in one amino acid. And it's not quite clear that the biological function really will be damaging to the function of that protein. And so the main message here is a VUS should never be interpreted as a positive result, and it is generally called uninformative until it may get reclassified over time. And over these past 30 years, we do find that VUS findings have become much less common as we're better at interpreting sequencing results. And most, it turns out, well over 90% will become reclassified as benign polymorphisms. So they get downgraded, shall we say. But interpreting and communicating these results is absolutely crucial to be done correctly. And this is an example of something that is not uncommon. And this is a case where in 2017, a woman had a VUS reported in MLH1, which is one of the genes for Lynch syndrome. And so this was incorrectly interpreted because the word variant came up that was incorrected as being positive. And so she was managed as if she had Lynch syndrome. Hysterectomy was performed. And ultimately, it was recognized that this was not indeed a positive result, and she should not have been treated as if she had Lynch. There was unfortunately litigation, and the case was ultimately settled. But I think it brings to light that there's a whole new world of genetic malpractice out there. And so it's important that test results are interpreted correctly. And I think we have not quite gone to the world yet where we're seeing that referrals or testing not being done as another source of claims in genetic malpractice. So I'd like to shift here and really talk about sort of where we are today and what are the options and available to you as you think about seeing your patients here and considering genetic testing. So we'll start first with what are the options that we have available. And in the old days, we would simply order. You think someone has FAP, you order testing for that one gene, and single gene tests are certainly available. But the trend now has been to really rely upon what we call these multi-gene panels. And multi-gene panels are simply just means you can sequence and analyze multiple genes all at the same time. And certainly the advances in next generation sequencing make this all feasible and very cost efficient. So the simplest panel would be, for example, what we call a cancer type specific. And this means, let's say someone comes to you with colon cancer, they're curious whether they have a hereditary colon cancer gene. So you can just sequence all colon cancer genes that we know of. And so this would be a panel of maybe 10 to 20 different genes in that. However, you can go beyond that. And so the next level of a panel would be something that we call a common cancer panel. And so now what this does is, this includes not just the colon cancer genes, but includes genes associated with other common cancers, such as breast cancer, pancreas cancer, prostate cancer. And the goal here is that many families may have overlapping clinical phenotypes that, yes, you had colon cancer, but your mother had breast cancer. And so maybe you're curious to find out about those genes as well. And in general, we will include on these panels just the high and moderate penetrance genes, the ones that are clearly associated with disease, and just what we call actionable genes. And so actionable is defined here at the bottom as genes that are a deleterious variant whose penetrance would result in specific defined medical recommendations that are supported by evidence, the implementation of which would be expected to avoid significant morbidity and mortality. So it's basically genes that we know what they mean and we know what to do about if you find them and they're positive. But then at the far end of the spectrum is you can order what we call one of these broad cancer panels, where now we're talking about 80 to 100 genes. And in addition to common cancers, we add genes associated with uncommon cancers, such as thyroid cancers, neuroendocrine tumors. And we also add genes that are some of these low penetrance genes, and also genes for which we have what we call preliminary evidence, meaning that we're not really quite sure how to manage them. And these would all probably fall into the category of what we call not actionable genes. So why would you choose among one of these? So I think that, this is where often, an element of having good genetic counseling and someone to guide you through the process is helpful. Certainly you can pick the cancer type specific one if you just want to know about the one cancer type. And I think many patients are going to be information seekers and they just want to know as much as possible. But I think that it's really more important to think about sort of what's the downside as you go up in terms of the number of genes that you look at. And I think this is where we enter the realm of what we call unexpected results. And so this is where if you start moving up to the common cancer panel, you can now anticipate you could imagine getting unexpected results, meaning you find out about risks for common cancers that are not related to either your personal family history at all. And in the broad cancer panel, you will find there's an even higher likelihood of getting unexpected results. And the challenge here will be that they're for uncommon cancers, and they're also going to arise in cancers for which we don't necessarily have good data about what your risk is and how we manage that particular gene. So I wanted to share with you, I think, an instructive example of a case that we saw in our own clinic about how unexpected results can really become quite the most challenging part of what we do. And so this is a young woman who's 23. She came to us because her mother had breast cancer at a relatively young age, passed away, and found out that her half-sister on her maternal side had gene testing and was found to carry a BRCA2 mutation. There was also a grandmother who had breast cancer, so it was grandmother on the paternal side. So she was concerned about breast cancer risk here. So she came in, talked about all the options, decided to opt for not just testing for BRCA, but really to doing this common cancer panel to look for other things as well. So she did the panel, and what she was happy to find out that her BRCA test was negative. However, she did come back positive with a gene for mutation in a gene called CDH1. And so CDH1 is the E-cadherin gene, and it is associated with a very rare condition called hereditary diffuse gastric cancer syndrome. And what this is it increases your risk for these, what's called diffuse or signet ring type gastric cancer. And the risk, it's an autosomal dominant condition associated with anywhere between as low as 30 to as high as 70% risk of diffuse gastric cancer.
Whoa.
And the current recommendation is that individuals who have this gene have a prophylactic total gastrectomy. And so this obviously came as a complete surprise. There's no gastric cancer in her family. It's not as if we had like a great option to say, oh, sure, we'll just keep watching. I think you're going to be at the low end of the spectrum. We'll just keep watching. And so this highlights the challenges. And I just want to talk a little bit about the syndrome to show you sort of what we confront. And so HGC syndrome has many, many unanswered questions. And so one of them, as I mentioned, is, does the fact that there's no gastric cancer in her family mean that maybe she's at the low end of that spectrum and maybe she doesn't have to worry? We don't know the answer to that. What is the right age? So the recommendation would be she's actually a candidate to have it done right now, but can she really actually maybe delay it? We don't know the answer to that. And then why isn't surveillance endoscopy effective? I mean, this, you would think we screen with so many modalities for so many other cancers. And it turns out the biology and natural history of this condition is very unique. And so this is an example here where in endoscopic view, someone with a completely normal looking stomach, but if you take random biopsies and look under the microscope, you can see that right under this normal epithelial lining are these tiny foci of what we call signet ring cancer cells in situ. And so these you cannot see endoscopically, but they're present in virtually every patient who has this condition. And so we're left with trying to kind of counsel her when we don't have the best data to understand her true risk, and that we don't really have great options to offer her in terms of either surveillance and avoiding a gastrectomy. I just wanted to share you some data on some patients that we have followed on our own clinic. This is about 48 patients, CDH1 positive, who underwent surveillance. And we looked into two groups, into those that either decided to just go ahead and just do the gastrectomy, and those that said, I just can't do it. I'm going to just keep surveying, and I want to take my chances, and we'll do regular endoscopy. And it turns out, again, the numbers are not huge, but this is a reasonable size given the rarity of the condition, that among those who opted for regular surveillance, that the longer term outcomes were really pretty similar in terms of no one died from gastric cancer. There were microscopic cancers that were seen. There was one individual who ended up having gastric cancer beyond the microscopic stage 1 and stage 2, who had a gastrectomy and is disease-free 5 years later. And there are many who are gone 10 years, over 10 years now, surveillance and without bad outcomes. And so it's possible that surveillance endoscopy can be acceptable, but I think we're at a point where we need larger data with a larger number of people. And so this is really about a plea for making sure that we develop the right kinds of databases and consortia for many of these rare conditions, so that we can actually understand in the long term how to manage these difficult cases even better. But I want to pivot now towards, with those options, so who should we be telling to get genetic testing? And so in the old days, we would just use what we call traditional high-risk criteria, and I'll talk about those in a sec, but really these were focused on really identifying individuals who are most likely to carry one of these conditions, because for many years, it was just so expensive to do the testing that you really wanted to target it to those individuals. But there have been growing calls to think about just doing what we call universal testing, and just saying maybe anyone who has cancer ought to get testing. And I'll talk about that. I think there have been some people far out making the claim that maybe everyone should just get testing. And I think there are some arguments why that might be a good idea, but I think that's nowhere near ready for prime time. So when we talk about traditional criteria, I clearly can't go into all of them for all the syndromes, but basically, we use a combination of young age of diagnosis, we look at family history, we look at whether there's certain combinations of cancers that go with the syndrome, and certain histologic features. And the specifics will obviously vary based upon the specific tumor type and the syndrome. And you can refer to resources like the NCCN in order to find those. There are a number of people who have created what we call risk calculators, so that they can help try to integrate some of that information together, so that it will give you a score to say what's the likelihood of a mutation, and this is someone should have testing. And those are available online and certainly useful tools. But let me just show you as an example. So these are the most recent guidelines from the NCCN about Lynch syndrome and what clinical criteria you should use when you're considering a diagnosis of Lynch. And as you can see, it's incredibly dense, incredibly detailed. It will take you a long time to read it, much less remember it. And what has happened is over the years is that we've gotten better at pinpointing and fine-tuning some of these criteria, but they're really just practically difficult to use. So what I want to do is just, first of all, before we pivot to thinking about universal screening, is just share with you, at least in the current state, because these clinical guidelines do have some use and utility. What would I share with you as sort of like the bottom lines about when you should think about referring in terms of GI cancer? So in terms of those who have multiple polyps, I think the main message here, and this comes as a surprise to some, is that if you have more than 10 cumulative colon adenomas, you really ought to consider an evaluation for an adenomatous polyposis syndrome. Certainly those with hundreds and thousands are straightforward, but it turns out as many as 7 to 8% of those who have in the range of 10 to 19 adenomas will indeed have an underlying positive genetic test. So these attenuated polyposis syndromes are out there. If you have sessile serrated polyps, 5 or more, 3 or more juvenile type polyps, or 2 or more Poitz-Jeghers polyps are all indications for referral and genetic testing. In terms of colon cancer, either a personal or family history, the question really ends up being, does someone have Lynch syndrome? And as I said, Lynch syndrome really accounts for the vast, vast majority of all those who have hereditary colon cancer. And the 3 things really to keep in mind are whether someone has abnormal, what we call immunohistochemistry, testing for the Lynch syndrome proteins on their tumor sample, early onset disease, less than 50 years, or a family history of colon and or endometrial, at least 2 relatives, those should all trigger a referral for genetic testing. And as again, I said, there are far more refined criteria that you can look up if you want, but those I think will capture really most of the people that we are concerned about. But we really are at a turning point now where I think we're recognizing that clinical criteria are just may have outlived their usefulness. And the NCCN has now recommended genetic testing for all patients with certain cancers. And these are the 3 now where genetic testing should be universally recommended. So the first one is ovarian cancer. And as I mentioned, ovarian cancer, the underlying mutation rate in ovarian cancer is as high as 20%. So if like 1 in 5 of your patients is going to have an underlying mutation, it makes sense that they get testing. And we also know that of those who have a mutation, the vast majority are going to have a BRCA1 or 2 mutation, which will make them a candidate for PARP inhibitor therapy. So for therapeutic reasons, it's essential that they understand their status. Just a couple years ago, the recommendation that all pancreatic cancer patients have genetic testing was also made. And again, the rationale is pretty similar in that about 10% of all pancreas cancer patients will have a germline mutation. And among those, BRCA2 end up being one of the most common ones. So again, for the same reasons, because how frequent it is and there are therapeutic implications, all pancreatic cancer patients. And most recently now, all metastatic, not all prostate, but all metastatic prostate cancer patients are recommended to have testing because, again, about 12% will have a mutation. And again, BRCA2 ends up being one of the most common. So for these 3, you definitely ought to refer. And in terms of how well we're doing, it turns out we're not doing as well as we should. So the ovarian cancer recommendation is now since about 2015, but only about a little over half of ovarian cancer patients are actually getting genetic testing. So there's a lot of room for improvement there. And certainly with pancreas, it's a relatively newer recommendation, but still we have a long way to go, that only about 25% are getting testing. And so I think it's important that to recognize that there are a lot of misdiagnoses that are occurring by not referring these patients for testing. So just want to show you a little about the data in pancreas cancer that kind of led to this recommendation. And so these are 3 important studies looking at thousands of patients with pancreas cancer, doing a gene sequencing in all of them. And this is what was found. So the panels were generally small or mid-sized panels, and about anywhere between 4 and 11% had an underlying any kind of pathogenic mutation at all. But if you just look at those who had a pathogenic mutation in a pancreas cancer gene, again, it was mostly anywhere between 4 and about 10%. So very, very common across many different studies. And I think one of the important other points here is that about very, very few, what we say, unexpected results. About only 0.4% of patients had an unexpected high penetrance gene that was found. Now, so-called hereditary pancreas cancer is a little bit of a funny concept because there are many, many genes that can increase the risk for pancreas cancer. And that's shown here in this pie chart where BRCA, ATM, PALB2, MLH1, P16, P53 mutations can all account for higher risk for pancreas cancer. So there's not like a single pancreas cancer syndrome gene. And it turns out that among these individuals that have these genes, only about 10% will have a family history of pancreas cancer. So family history is not a useful guide for someone who might require testing. And then among all of these genes, BRCA2 and ATM end up being the two most common. Now, all of these genes, you've probably heard of, because these are all genes that are actually more commonly, more frequently associated with other types of cancers, such as breast cancer and melanoma, and not pancreas cancer. But nevertheless, they are still have high risks of pancreas cancer, and the fold increase is shown here. So Poitsiegers, for example, probably has the highest risk, a fold risk, about 130-fold risk over the average person in the population. The P16 familial mole cell syndrome up to 40% risk. And so, so it's important to recognize that, these individuals are hard to recognize because there's no family history. It can be a multitude of different genes, and there are therapeutic implications. So it is absolutely critical that these patients get genetic testing. Now, should we be doing this for all other cancer types as well? And I think that, the tide is turning. And I want to just tell you a little bit about where we are in terms of doing that for colon cancer, as whether we ought to be just doing that for every cancer type out there. So a couple of studies have looked at, sequencing everyone who has colon cancer for one of these genes. And the data are not exactly the same. There are some interesting nuances. So these two studies, again, over a couple thousand in patients, one using a small, the so-called common cancer medium panel, one using one of these very large panel with a lot of unactionable genes. So about anywhere between 10 and 15% will have any kind of mutation that's found. But if you focus just on the genes that are associated with high risk for colon cancer, it ends up being somewhere between more to about 5 to 7 or 8% will have an underlying colon cancer gene. So it's far lower than many of the other things that we talked about, like pancreas or ovary, for example. And it turns out the vast majority of them are all going to be genes associated with Lynch syndrome. So it's not really like there are a lot of other syndromes to be concerned about. It's really about identifying whether Lynch is present or not. The other thing is also, if you look at unexpected gene results, we actually see a much higher rate of unexpected results, anywhere between 1 and 2%. And most of these end up being BRCA genes in families which don't really have any suspicious features for hereditary breast ovarian cancer. Some cost effectiveness studies have been done and it suggested that incremental cost effectiveness is probably not cost effective to do universal gene testing in colon cancer. So where do we stand in terms of, if you try to balance out, should we do it or should we not do it? And this is, I think, these kind of arguments apply to really every cancer type. And for colon cancer, I think that the reasons that it's worth doing it is that it's just simply so much more efficient, right? You don't have to remember all of those criteria, family history, age, etc. And you end up having a much more reliable identification of hereditary cancers. And it turns out about half of all the cancers that are identified who have a pathogenic variation would not have met clinical criteria for testing. So it's just simpler, easier. You're going to find everyone and more people that way. And you can find unsuspected syndromes that you do want to know about. However, on the con side is that, doing testing is not going to impact most patients. We actually have other ways to find Lynch syndrome, which is by doing tumor screening. The therapeutic implications actually in colon cancer are actually quite minimal. So there are no real targeted treatments associated with carrying a Lynch gene right now. And certainly these genes that were used, PARP inhibitors, are not associated with colon cancer. As I said, the cost effectiveness is a little bit uncertain. But I think one of the biggest logistical hurdles is that the system really just had limited capacity to accommodate testing for so many more patients than have not had it. And at colon cancer, if we say 150,000 cases a year, a mere fraction of those are getting testing now. And if we open it up to everyone, as well as those who haven't had testing in the past few years, we would really overwhelm the system. However, the bottom line is that, balancing all of these pros and cons, I think the NCCN has now weighed in and recognized that the pros probably still outweigh the cons, and that universal testing for colon cancer is now an acceptable option. Now, it is not recommended as the only option or the preferred option, so that using clinical criteria is still reasonable, but I think the pendulum is now swinging that universal testing is going to be in the future for all patients with colon cancer. And what about patients who have any kind of solid tumor? And I'm just going to show this quick slide here on three important studies that looked at all comers with all solid tumors and how often do you find an underlying gene mutation. And I think the key points here are that, so this study looked at the huge panel, this study looked at the smaller panel. The rate of finding any mutations anywhere between 7 and 17% of all cancer patients. If you look at the genes, colon tumors we talked about, we can see here that, the rates are kind of in that same ballpark, 5, 6 to 10, so to 15, 20%. But I think one of the most instructive lessons is that for cancers for which we normally don't do testing, like lung, bladder, biliary, still very high rates of underlying gene mutations in between, again, 5 to 15%. And so these are people that never would have been offered testing in the past. And just as a sideline, that among the mutations that are found in the whole population, BRCA and ATM, just population-wide, appear to be the most common ones that we see. But I think that the pendulum is swinging, and that it's going to ultimately become more of a viable option to basically test anyone with cancer, although that has not officially made it to any recommendation yet. So I want to move on to wrapping up with sort of looking at what does the future hold and what are some of the challenges that we need to address as we think about sort of even more widespread testing. So one of the most important ones is, as alluded to, that CDH1 example, is that we need to do better at being able to have more precise and accurate genotype-phenotype correlations. And this is tough when the cancer risk can be so variable in a certain gene. And how do we balance that with effectiveness and morbidity of various screening strategies if we don't know that we don't have proven approaches that can be highly morbid. And I think the point here is that we can find genes pretty quickly, but understanding their biological significance takes much more time. And I think that we will continue to work on that as we go forward. The other piece of low-hanging fruit that I think we need to do better on is that we need to increase the low rates of what we call cascade testing. And so cascade testing is defined as genetic testing that's done in family members at risk after a pathogenic variant is identified in a program. So once this is recognizing that these are all conditions of not just individuals, but of families. So if a patient of yours does indeed have a mutation, relatives are going to be at very high risk, 50% of also having the gene. But it turns out we don't do very well at informing relatives and having relatives get testing. And in recent studies, the rates are as low as 18% of cascade testing. In a slightly more optimistic review, suggested maybe we can do as high as 50%. But it's a cost-effective strategy that can indeed obviously reduce cancer and save lives in people who are at high risk. The challenge is that this system of cascade testing relies upon patient notification because of privacy and HIPAA issues. Providers really are not free to go and inform relatives about this risk. And so novel and unique and creative strategies to help communication with patients about this is critical. But I'm going to end on just what is probably the most burning and challenging logistical issue, is that how do we address this growing demand in indications? Meaning that we traditionally have patient see genetic counselors, get counseling and testing, and really that model is, I think, going to be obsolete. There are only about 4,000 genetic counselors throughout the nation, and they cannot handle the current workload, much less the workload if we expand indications going forward. The for-profit companies have made a foray here. 23andMe now offers a limited number of cancer gene tests. However, there are concerns about quality and false positives, as well as appropriate medical follow-up. There have been strategies to try to make genetic counselor time and use much more efficient, where they do televisits or do counseling with groups of patients all at once. And while some of those are effective, they really are only just going to make a dent into what the demand of what we need. And so really the focus has been trying to develop alternative models without using a genetic counselor. And the key here is trying to figure out how do we ensure appropriate education and consent in that testing process. And the main view, one of the main strategies has been to do what we call mainstream genetic counselors to non-genetics providers. But also what we have been interested in is looking at new electronic tools that may help with this process. So mainstreaming is where we use non-genetics providers, mostly oncologists or PCPs, to be able to take a more active role in this genetic testing process. And I would say that oncologists, there has actually been great progress along this front. And we see mostly among breast and GYN oncologists. I think there's a lot of comfort and in terms of managing BRCA, which has been around for a while. There still are barriers in terms of many providers feeling they don't have enough knowledge or time. But a number of studies have showed that it is quite feasible as long as you have appropriate training for providers and that you do have assistance with genetic professionals in terms of disclosure of test results. Remember, the vast majority of people who have testing will all have negative results. So it's really helping out with those positive tests. Satisfaction appears to be pretty high, and much of this revolves around the fact that these patients often get testing done much more quickly when they're already seeing their oncologist. However, how generalizable this is going to be in terms of being able to offer and understand and explain all these different test options and extend it to oncologists who manage many other cancer types who aren't as familiar with genetics remains to be seen. PCPs at this point simply, I think, are overworked and overburdened, and surveys have indicated that they just do not feel comfortable in terms of their knowledge about genetic testing, their comfort level, as well as how to interpret genetic test results. So we are now exploring a new tool, and we've developed a tool, which is an electronic decision aid for genetic testing to use in inherited cancer syndromes. And this is a project that's been funded by the NCI Cancer Moonshot Initiative. And our feeling was that we want to harness electronic tools, but also use something called a decision aid, which technically is something that can help educate patients as well as facilitate shared decision making. And we feel that with this tool delivered on an iPad, delivers appropriate education, explores the pros and cons about the different multi-gene panel options, is interactive in that it takes into account patients' values, patients' preferences. With electronic aid, you can use this in terms of flexibility about when and how you use it. We designed it to be used with an oncologist in an oncology clinic appointment. And at the end of using this aid, the consent and order is then, for the blood draw, is done through the oncology provider. And the tool focuses on two primary decisions: whether they want to have genetic testing, and then which multi-gene panel to pick. And we think having that choice is actually incredibly important. And this is just to show you a couple of screenshots from this aid where we introduction to show you what the tool is all about. You scroll through tests, exploring the benefits and the downsides of doing testing, as well as surveys exploring what are some of the priorities and values which might inform what kind of testing they want to have performed. So we have completed a pilot study of this of ovarian cancer patients both at MGH, and we have enlisted collaborators at Boston Medical Center. The tool takes only about 13 minutes to complete. All patients agreed to pursue genetic testing at the end. And when we assessed feasibility and acceptability, we found that measures were high on both. So patients, in terms of satisfaction, 96% felt the tool was just right. Nearly 90% felt that the amount of information they learned was just right. Knowledge scores increased before and after use of the tool. 91% felt the tool was helpful making their decision, and 91% would have recommended the aid to other friends. And in terms of the providers, we're all extremely very satisfied with the flow of the visit, with how well they felt that patients were informed, and that that the clinic time was not extended significantly. So the interesting thing here is that in terms of the choice of the panel, there was no consensus, that patients really had a wide variety of preferences. About 15% chose just a cancer-specific panel, but it was split even between those who wanted the sort of common actionable cancer panel and those who wanted to just go for it and get everything done. And we think that this highlights the importance of choice and not just offering patients a single panel. So we now have a randomized controlled trial underway using this aid, comparing it to traditional counseling to just make sure we're evaluate knowledge, things about regret and shared decision-making. We're expanding it to pancreas cancer patients as well. And we do have translated versions being able to improve access to diverse populations. So I just want to wrap up here and just highlight some of the key messages that I've been able to share with you. Genetic testing is the standard of care. The key message here probably is that syndromes are indeed common. They often do not exhibit classic features, and they are under-recognized. Targeted treatments are available, and risk-reducing strategies are effective. So who needs to have testing? Pancreas, ovary, metastatic prostate, everyone. These are some of the key clinical features to think about for colon cancer individuals, but I will say that now referring anyone with colon cancer for genetic testing is indeed an option. Should everyone with cancer have genetic testing? I will say that not yet, but I think in the near future that is going to become a reality. And in terms of which panel is the best to choose, I would venture to say that choosing the common cancer panel is probably the default option. And it will be a discussion with your patients about whether they want to scale down or scale up, but being prepared for unexpected results as panel size increases. And finally, increasing access. I think we're going to rely a lot on non-genetics providers, particularly oncologists, but we firmly believe that electronic tools are going to be able to allow us to expand to even more patients in a more efficient way. So I just want to thank a number of individuals who have worked with me in my group and are currently working on this particular project with our genetic aid. And I wanted to just end with this final photo memory. just to highlight, this is on commenting on something Bruce mentioned early on. So this is a photo of our GI division in 1992 at Mass General Hospital when I was a fellow, and Mark Babiatsky right here was a junior faculty member. And I had the privilege of working with him in the lab, where he was just a constant source of wisdom, advice, enthusiasm and energy, and someone who is dearly missed. I do just want to also highlight someone else. Bruce, of course, here was in our was part of this illustrious group, and here he was 30 years ago. So I'm going to end there, and I just want to thank you all. It's been an incredible pleasure and honor to be with you, and thank you again for your attention.
Thank you so much, Dan. That was an incredible talk. It was really so accessible, and in the spirit of Mark's interest in genomic medicine, really so on topic. So I really thank you. We have just a few minutes for questions, and many did come in while you were talking. I want to give the first question to Dr. Kraft, if you want to ask it out loud. So I have to unmute you. I don't seem to have a way to do it, so I'll ask.
Yeah, it's only Francine can do it.
Okay.
The keeper of the mute button. Yes, thank you. Hi, really nice talk. Very much enjoyed it. You had made a comment, which is not unusual, that a positive result could mean you need to put it together with the clinical relevance. And so, and you may have mentioned this, but I want to be sure I heard it, is that there's access now to lots of great databases. All of us, UK Biobank, of course, we're doing the Mount Sinai Million right here. And so wondered how helpful do you think that would be, or how much are you already doing really to integrate positive results with the EHR and to try to understand clinical relevance, phenotypic characteristics that may prompt an evaluation in the setting of positive result, just to understand the clinical relevance?
Yeah, no, that's a great question and a great point. And I think that, we here are involved in a number of projects like that. There's a so-called Mass MGB Biobank where we have just, and are participating in, all of us as well, in terms of trying to understand, beyond phenotypes, beyond just cancer risk, but other genetic risks as well.
Sure.
And you are correct that I think that the instructive things about all of those is that we are learning that many people carry these genes who don't have any clinical phenotype at all. And so it is incumbent on us to kind of amalgamate really all of this data with larger populations to truly understand how to tease out that risk. Because as you pointed out, the bottom line is that in the end, what are you going to tell your patient what that means? And until we have, I think, more annotated data with these larger groups, we're not going to be able to do that successfully. And so that ends up being the biggest risk for patients. Like, do you want to learn about something that we don't know what it means yet? And that is where I think, a little bit where the technology of our ability to interpret it.
Right.
But yes, but absolutely. I think it's just going to be a matter of time, but I think that using these large resources and databases will give us some clues to that information.
Great. Thank you.
Yeah, there are other questions, but unfortunately we are out of time. But just one last thing, which is I would present it to you in person if you were here, but this will be coming to you in the mail. But this is a certificate that really recognizes you for this wonderful talk and will help you remember our friend Mark, and I'm sure you'll display it very proudly on your wall. And thank you so much.
Well, Bruce, thank you very much. It's really just been a tremendous delight and honor. So thank you again.
And thanks to everyone for attending today.
Thank you, Dan. Great talk.
Thank you.
Thank you, Dr. Chung. Very much appreciated.
You're welcome. Thank you, David.
Thank
Have
you
a good
so
day,
much.
everyone.
Bye, Dan. Hope to see you.
Bye-bye. All right. Talk to you soon.
Have a good day, everyone.
Okay.